Good Things Foundation, and they'll be kind of sharing their own experience of pieces of work that they have done. Just quickly, I'll go through the agenda. Bear with me. Oops. Yeah, this is what the agenda looks like. So we have Urta from Healthwatch England, who will be sharing our findings. Mike from Healthwatch Haringey sharing a case study. Alice from Good Things Foundation will be talking about the digital divide. And finally, we have Charlotte from Age UK, who will be discussing a piece of research that they have done recently about Too Old to Help. And we also have like a question and answer session at the end, so you can share your whatever you have to share or you have to discuss with us. And just a few quick housekeeping reminders. Again, if you can please keep yourselves on mute when you're not speaking. The video function is there, so feel free to switch it off if it helps with your bandwidth. But I'll request the presenters to please keep them on when you are presenting your slides. This is the chat and the raise hand function. Yep, just use them to place any comments or if you want to say anything. And finally, to let you all know, we are recording this session and it will be published on our website. So with that, I hand over to Urta.
Thank you. Hi, everyone. My name is Urta. I'm a senior policy analyst at Healthwatch England. I can see someone in the chat is saying they can't see any slides. Let me share my slides and then we'll see if there's still a problem. If you're still having a problem, I would suggest leaving and then rejoining. That can sometimes help. Okay, can people see that?
Yes, we can, Urta.
Great. Okay, so I'm just going to give a brief summary of the work that we've recently done. So hopefully many of you will have seen our report, Locked Out, which was published a few weeks ago. So for this piece of research, oh, my slides aren't changing. Oh, here we go. So for this piece of research, we worked with 5 local Healthwatch. It was a qualitative piece of research, so we wanted to really do a deep dive into people's experiences, following on from some work we did earlier in the year on people's general experiences of remote care. So for this piece of work, we spoke to 86 patients and 26 members of staff with in-depth interviews, and we focused on older people, people with disabilities, and people for whom English was a second language. And that was based on literature review that we did, which kind of indicated that these were the groups of people at greatest risk of digital exclusion. So in the report, we talk about how people find it more difficult to use remote methods for a variety of reasons, including limited interest, lack of digital skills, age and disability, lack of trust, language barriers, and affordability. And yeah, in the report, we kind of tell some of those stories of people's experiences. And of course, if people fall into multiple categories, they can find it even more difficult. It was quite frequently that we heard that people just simply weren't interested in accessing healthcare remotely, even if they could. And I guess we would kind of challenge that narrative that that's just about interest, because oftentimes behind that there can be other needs that are unmet that makes it more difficult for people to access care remotely. So it probably won't surprise you to hear that through the conversations we had, we found that people found it more difficult to access face-to-face appointments during the pandemic. If people felt they needed a face-to-face, they were usually able to get one, but they had to be very persistent, and they had to first have a phone appointment and be very persistent in trying to escalate to have a face-to-face appointment. In terms of people's experiences of remote care, it can really improve people's experience for some people, and it can create barriers for others. Again, probably not surprising, but those people weren't always, kind of the people you'd expect. So some people who traditionally would experience more barriers to accessing care actually felt that remote care improved their experience. For example, people with mobility issues for obvious reasons. Remote care makes it easier for them. People with caring roles also found that being able to have a phone appointment was able to fit in with their schedule much better. And for a lot of people, remote care just works because it's easy. But people did experience barriers. The most common complaint that we heard was around the difficulty of getting an appointment in the first place, with this kind of total triage model where people need to, before they're given an appointment, describe something about their condition. So with phone lines were frequently very busy and appointments already fully booked up. And yeah, again, with the total triage system, a lot of practice surgeries are now using online systems like Ask My GP for people to request appointments. And in some cases, people are being told that this is the only way to make an appointment and are not actually getting support from receptionists to make that booking. And in several cases, this led to people, abandoning attempts to seek care because they didn't know how to access the app. Yeah, of course, language barriers can be an issue, and there was a lot of variation we found in the way that people use interpreters. In some cases, practices did use phone interpreters, and in other cases, they said that they weren't able to use phone interpreters. Yeah, and people experienced a range of other challenges quite specific to their condition, which we talk about in the report, as well as frustrations similar to the general public experience. One of the main complaints we found in our previous work was around not knowing when a doctor will call. But for people in these groups, that was even more frustrating because they frequently had to have a carer or an interpreter with them to also support them for the appointment. So that makes it even more difficult for them. Overwhelmingly, people told us that they want choice over what kind of appointment works best for them. And in general, people understood why things had shifted to remote care during the pandemic, but they were worried that this would become the only option, and that if that was the only option, then something would really be lost from their care. We also spoke to staff. As I said, we spoke to 26 members of staff for this piece of work, and in general, staff expressed broadly positive views about the shift to remote care. They felt it in many cases allowed them to work more efficiently, and it was in line with the kind of transition towards digital NHS, which was already happening. And for many people in their practice, it just works and it's easy. But staff, almost all staff, did also acknowledge that the pace of change to remote care was extremely fast, and they felt that the shifting to remote care overnight meant that some people sort of fell through the cracks, and they did acknowledge that some people, particularly in the groups that we were speaking to for this piece of work, were struggling and experiencing barriers, and in some cases this meant that they weren't seeking help. And yeah, most staff said that they would like to maintain the use of remote appointments going forward, but they felt that there should be a rebalancing and an increased number of face-to-face appointments when compared to the kind of acute phase of the pandemic when everything was remote. I won't dwell on this too much because Mike's going to speak about the case study of a digital support project, but we do talk within the report about the different ways that people could be supported to access care remotely through various support projects, but also ensuring that people have access to an interpreter at all appointments, and giving people support for total triage system. And within the report, I'll quickly go through the 5 recommendations that we make within the report, which we can discuss more in the discussion section. So the first is that we need to make sure that as we come out of the pandemic, that we have a kind of hybrid model where remote methods clearly work for some people, but traditional models of care need to be maintained, and patients should be supported to choose the most appropriate method of care for them, which isn't just about giving people what they want for no reason, but it's actually really important to allow people to manage their healthcare and their needs most effectively. Secondly, obviously, if the ambition is to maintain digital NHS and the shift to remote care, then we also really need, a national program of investment in digital skills. as we come out of the pandemic. And there are lots of fantastic local initiatives on this, but this shouldn't just be left up to local discretion, and there needs to be a big national commitment to improving digital literacy. Third, clearly there's a number of areas where there's a lot of variation in the kind of support people receive, particularly around interpreting. And we think there needs to be a kind of national clarification of the rights that people have, to make sure that when people are using remote care, that people with support or access needs are not having a worse experience. Fourth, this is something, this is a kind of behind the scenes point about ensuring that data collection and patient record systems actually support practices to record and proactively take account of people's support needs, and that this can be passed on to other services when people are referred. And finally, if the NHS is going digital and that's kind of national ambition, then there can really be no excuse for allowing costs to create a permanent barrier to accessing the NHS. And access to the internet is clearly becoming more and more an absolutely essential service to access both healthcare but other essential services. So we argue that in the long term, the government should treat the internet as a universal right, and think about ways to underpin kind of universal access to the internet to ensure the NHS remains genuinely free at the point of use. So that's the end of my bit, and I hope we can discuss all of this after the other speakers have come on. Thank you.
Thanks, Etta. If I can invite Mike now, Mike Wilson from Healthwatch Haringey.
Hi, thank you. Welcome to everybody. Just try and get my webcam on. Okay, I haven't got any PowerPoint slides to put up, but I do have a slide pack, which is more than I'm just going to talk about now, which I'll send to Erti and for circulation to anybody who's interested. So just briefly, in Healthwatch Haringey, we've been running a project now since January this year. It's funded by the CCG, North Central London, and 3 local hospital trusts, and North Central London digital support. There's a fair bit of funding in there. We've got funding for devices and connectivity, and we've got funding for a project team. The idea was to set up a project team for 6 months to explore how we could support patients get appointments and get consultations remotely, both for hospitals and for GPs. It's been successful enough to have been rolled on, and it's going to be rolled on again. That's not to say we haven't had a lot of issues and barriers, which I'm more than happy to talk about, because it hasn't been an easy process. And you probably will understand why. So the reason they were funding it was because there are fewer patient-facing appointments, more remote video consultations. All GPs now have adopted a model of triage, and if you go onto patient access or your NHS app, you won't be able to make an appointment. You can only do that by phoning up and hanging on, in most cases, for some while before somebody answers, if indeed they do. It's convenient for many. We've done some surveys locally, and quite a lot of people really like it, but others don't, and they can't actually use the systems for one way or another. So what we've been trying to do is to improve patient access to digital health services. That includes the mental health trust, acute services, and primary care. So we've been helping people cope with online inquiries and consultations, video appointments, ordering prescriptions, appointment bookings, that type of thing, helping them get onto the NHS website, using the mobile app, and GP, hospital, and other healthcare provider websites. One of the challenges is, and you may have found this yourself, if you go onto the websites, they're usually out of date. So, and it's very hard to find the information you want. So that can be quite a challenge in itself. So we've also been involved in specific health service programs, monitoring systems and management courses, which I'll say a few words about in a minute. And then sort of general health info, group video meetings, well-being, mental health courses, and helping people deal with the general issue of social isolation. So one of the challenges we found is that out of our sort of 40 odd GP practices, they don't all use the same systems. Some use eConsult, some don't. Most seem to use AccuRx. Some use a new system called Patch that we'd never heard of. So these things sort of spring up overnight. And in order to help people access their GP, we have to be able to understand what the system is, they need to access, and then understand how to do it. So that's certainly been more challenging than we expected. But we're on the case, but it'll keep changing all the time. So our CCG were promoting eConsult, for example, last year. Then all of a sudden they decided to stop promoting eConsult and said to the practices, you don't have to use it if you don't want to, it's up to you. A number of them stopped using eConsult. Others have carried on. One of the reasons for that was some of the GPs found eConsult difficult to cope with because they got so many eConsult forms in, they couldn't cope with them. So that was causing them a problem. So yeah, these things aren't easy. So the sorts of services we've been helping with are remote video consultation. So we help people use the AccuRx system, which I think most GPs tend to use. It's a link sent to their smartphone and then have to do a few things on their smartphone and they can get into the consultation. Local hospitals use something called Attend Anywhere. It's a different system, but it works in the same way. It's about sending a link. We help people with eConsult process and the inquiry system, and then a range of GP services. So patient access, My GP, the NHS app, and this is a new thing called Patches. So we provide some support for those people. And then other digital health services. So the NHS websites, mental health resources, COVID resources. We've recently got involved in helping people with remote diabetes monitoring, which was something we hadn't anticipated. And one of the reasons for the action research sort of set up was to explore, what the possibilities might be. That is definitely a possibility. So there's a lot of remote monitoring for diabetes and dietary programs now, but you can only use them if you've got a smartphone and you know how to use it. So we've been helping people do that, and with self-management courses. The other demand's been for Zoom and Teams for group meetings. That's been a bigger demand than we'd anticipated. We thought it was all going to be about the consultation element, but actually we've had a big demand for people to know how to use Zooms and Teams, creating an email account, because a lot of these systems require you to have an email. Many of our older patients don't have an email account, and many of them actually don't want one. So that's a challenge in itself. So we help them create an account and explain to them how to use it. We have enough money to lend smartphones. So we've got a number of smartphones which we lend out for people to use. And we've got a central mobile device management system, which is a bit of software that controls all those mobiles that we've got out there. So we know what they're doing and can stop doing things that they shouldn't be doing, and we can keep track of them. We've got about 50 at the moment, and we've got enough funding for another 150 if we wanted to. What I should have said is, right at the beginning, that this program is being delivered by volunteers. So the volunteers are trained. We've recruited about 40, and they receive training to enable them to provide all the support that I've now been talking about. Because it's NHS, because we're getting referrals from GPs and hospitals, the whole system had to be checked for information governance. So it's very secure. Our CRM system, which we've used for other projects, is secure, but it had to be tried and tested. So referrals come in via a web form into our system. It creates a referral in our CRM system. Then we triage it. That's an issue as well, because often the referrals don't say exactly what the patient wants. And then sometimes you phone the patient and they're not quite sure what they want either. So once we have identified a need, a volunteer is allocated, and then a session is started. At the moment, they've all been remote because of COVID, other than some which have been in community hubs. So we've had some in libraries. We've got 2 libraries that have stayed open during COVID, and we've done some consultations in the libraries, and that's been quite tricky, but it's very successful, and particularly some of the mental health related consultations, people joining in their counselling group or whatever. That's worked extremely well, and we have managed to deal with people who speak Turkish and other languages, and then we arrange another session if necessary, just to make sure that they can understand what they're doing, and then we follow that up with the referrers and the clinicians to let them know what's happened. So that's it. More than happy to talk about the challenges, of which there are many, which probably explains why there aren't that many comprehensive digital support services around, because it is pretty tricky, and it's taken us much longer than we anticipated, in all honesty, but we have got there, I think. So if you're happy, that's it for now from me.
Brilliant. Thanks, Mike. That's really useful. Thank you. So next we have Alice Mathers from Good Things Foundation. Alice, do you want to share your screen?
Yes. I don't think I have rights to share at the moment. I did before, but they seem to have disappeared.
In that case, maybe you can just perhaps talk through your slides.
Sure. Lovely to be with you all this morning. So my name's Al Mathers, and I'm Head of Research at Good Things Foundation. So Good Things Foundation is a digital inclusion charity, and our focus since 2010 has been on ensuring that as we move towards an increasingly digital world, that's a world that everyone should benefit from, and people shouldn't be left out. So far, we've supported over 3.6 million people since 2010, and a huge proportion of these, over 2.9 million, would count as socially excluded. And that's really important, as the overlap between being digitally excluded and socially excluded becomes even clearer. We work and have impact through working in partnership with thousands of community partners, and that's really critical. Just as the previous speaker was talking about, those are the kind of hyper-local community-based organisations. They could be libraries, they could be community interest groups, they could be GP surgeries based in communities across the UK and also in Australia. Digital exclusion is a really, really big issue. Today in the UK, a huge proportion, 2.6 million people, are still offline, and 1.5 million households have no internet access. This comes to the forefront when we think that actually digital inclusion is kind of a three-part thing. It's about having access, so that's having your own personal device, enough data and enough connectivity. It's also then about having the skills to use that device to do what you need to do online and achieve your goals. But it's also about having the motivation and confidence to do that. And that's where we find a lot of people are actually still struggling. The digital world and transformation has accelerated, but the confidence and the trust and motivation to do things digitally isn't always there for all people. As all of us will be aware, COVID-19 has actually brought into focus and increased the digital divide for some people. It's affected us across all areas of life, as well as healthcare and well-being. It's also affected people in terms of jobs and education, social connection, participation, links with communities, being able to access your money, your benefits, your payments. And therefore, if you don't have access, skills, confidence and motivation, there are many areas of life that you're being disadvantaged currently. Lack of personal access, as I was saying, is a big issue. This relates to people just not basically being able to afford it. So we've seen over the past year and during the pandemic a rise in kind of data poverty, people having to choose between data and food, data and being able to pay your rent. There's also a real issue around lack of people having suitable personal devices. So if someone has been trying to access whether it's health appointments, but at the same time trying to homeschool children, actually paying for data for video calls, being able to do that on suitable devices has been a real issue amongst many people who we work with. Also, we see that actually there's a growing proportion of the population who are only smartphone users. About 10% of internet users only use a smartphone to get online. So things that have come into play around things like two-factor authentication, and increasingly when we're trying to make safer and safer services, we're actually locking people out who may only have limited device access, may only have one device, may only have a shared device. And so that's a growing issue as well. In terms of lack of digital skills, actually, this isn't just an issue about as we age, we may not be so digitally engaged. 10% of all people who lack digital skills are under the age of 50. And 55% of those people who are offline earn less than £20,000 a year. And a huge number of people, over 20.5 million adults in the UK, actually have very low digital engagement. So that's the issue around not wanting to do certain things online, not having the motivation or confidence to do things online. Nearly half of those people who are offline currently say that it is just due to a lack of interest, and this is quite a stark finding, as it has actually gone up 11% in the last year. And the reasons why people don't want to be online or don't want to do certain things and interact with certain digital services are about it being too complicated, they're not interested, or they don't think they need it, or generally they see it as being too expensive. And hand in hand, this goes with a lack of trust. So there is also a rise of internet security related concerns. So as we increase digital first services or digital services, there is also a really big issue around people and their trust around their use of their data. What we've also seen is that it's not just an offline-online divide anymore. We see a growth, as I was saying, in this kind of area of people who are limited users, people who are at most at risk of just doing a few things online and then turning around and realising the thing that they did face-to-face or over the phone no longer is available. Generally, these are people who are older, who are from lower income households, and who are generally more financially vulnerable. They often have left education earlier, may live in areas where there's poor connectivity, remote or rural areas, and often live with an ongoing health condition or disability. And a lot of these people, when we're talking about their limited use, they may feel comfortable doing things like WhatsApping family members or using social media, but when it comes to kind of more formal uses of the internet, interacting with services, finding information, they're very unconfident in these areas. So this matters obviously because increasingly government services, as we've talked about in this session, like health, benefits and tax, are all going online. But it's not just that, it's the wider wraparound of services that are going online. Utilities, banking, shopping, all accelerated during the pandemic by the necessity that happened during lockdown. As I was saying, it's also affecting areas where there's an overlap between financial exclusion, digital exclusion and health inequality. So people are being shut out of being able to apply for jobs, being able to secure their income, being able to get a device, being able to pay for connection. Good Things Foundation has been working in the area of digital and health for a number of years. So since 2013, we've been working with the NHS on the Widening Digital Participation Programme, and that ran from 2013 to 2020. It was a national programme, a very big scale investment looking at this interaction where we see that digital has become actually a social determinant of health. And the approach we took through this programme was focusing on co-design, supporting particular groups of people and working with people who lived with certain health conditions, looking at this idea of community-based health support, health hubs to help build digital confidence and skills, And then also working with health professionals, where actually we were seeing there was also a disconnect about that level of digital confidence and being able to support other people or patients who came in with using digital tools to help manage their health. As part of this programme, there were 23 locally led pathfinders, and they focused on things including digital health literacy, supporting people and working with people who lived with dementia, cancer, working with different refugee communities, and working with different social care providers. Through the programme, over 21,000 people were supported, and 824 people were involved in those co-design pathfinders. And as a result, over 1,350 digital champions actually started taking that kind of role of supporting people with that link between digital and health in their community. What's really important was that we were addressing various challenges around digital health literacy, so building those skills around how to access NHS services or trusted information online, but also providing that kind of contact and face-to-face support. So it wasn't just about learning, it was about addressing motivation and trust. In terms of lessons learned out of that programme, key was recognising digital access and skills as a social determinant of health, that we should be focusing on co-designing digital health services, that there is a gap at the moment. We really need to improve digital health literacy across the population. This isn't a minority issue, it's a majority issue. To sustain that momentum, to look at the development of digital health hubs and nationwide coordination of that, to provide places where people could get that support and that information and improve inclusion. It really was very important to build trust and relationships with poorly served groups, and that was why the co-design approach was really critical. And to harness the benefits of digital for health and wellbeing, to make that link, to make sure that digital inclusion wasn't a bolt-on, it was a route to better management of your own health. It was also really effective in improving digital skills in the health and care workforce. We worked with many CCGs and integrated that understanding. And finally, it focused on embedding digital inclusion in health and wellbeing strategies. I'm delighted to have seen Healthwatch England's report today, and what I've looked at is really how there is a join up in recommendations of work that we found through the National Widening Digital Participation Programme. And in terms of Healthwatch England's recommendation about investing in support programmes to give as many people as possible the skills to access remote care, we would back this up by saying it is important to now invest in that national coordinated approach to community-based digital health hubs, particularly as the changing landscape at the moment, restrictions lift or we go back into certain situations. There is an ongoing need now to be able to build people's digital skills, confidence and trust in accessing services so that health conditions don't go unmanaged. It's really critical also to promote the benefits of the internet for all people. Addressing motivation is critical now, building trust is critical now, so that people don't stay limited users. It's also important to provide free essential digital skill support, prioritising those people who may live in low income or poverty. It's really important that the digital divide therefore doesn't grow. Secondly, as Healthwatch England have recommended, in terms of enabling practices to be proactive about inclusion by recording people's support needs, we would also say that there needs to be funding of holistic approaches that meet wider needs. And there needs to be a real focus on ESOL support and accessibility support. Again, we would reiterate co-designing health services with people with low digital access and skills and poorly served groups will mean that services are more future-proof. And in terms of committing to digital inclusion by treating the internet as a universal right, again, we would fully support this. And it's about that embedded approach, not bolt-on approach of digital inclusion in all local and national services. It's about considering digital confidence in the workforce, in all kind of at all levels across health services, from receptionists through to community nurses, midwives. That kind of idea that everyone has a role as a kind of a digital champion is really critical, and giving people confidence to do that. It's also about harnessing the power of peers to build skills and motivation. We've found that actually, if people get confident, the most likely thing they will do is tell their friends about the benefit of using a certain digital tool or app. And in terms of the knock-on benefits around building trust, that is absolutely critical also. And thank you. That's me finished.
Thanks, Alice. Thank you very much. Next, we have Charlotte from Age UK. Charlotte, are you able to share your screen?
Yes, I think so. Let's try and see. Has that worked at all?
Something's coming up.
Yep,
we can. Thank you.
Great. Yeah, thank you so much for inviting me along today. I'm going to talk briefly. I think I've got about 10 minutes to talk about older people's experiences of digital exclusion and how this is related to their experiences during the pandemic. Quickly, just to summarise, can you see all my notes as well? Is this?
No, we can't. We can just see the slide. So
okay, great. I could see it all a little bit looking odd there. Yeah, so we've spoken to a really broad range of older people actually around their experiences of accessing healthcare during this time, and some of the barriers they faced in doing that. So first of all, we've spoken to around nearly 15,000 people, majority of those are older people themselves, but also some of their friends and family, to understand a little bit more about their experiences of accessing healthcare over the last year. We've also backed this up by some representative online polling with older people. And then we've also done some ethnographic research with older people in a joint project with the Salvation Army, looking specifically at older people who are socially excluded. So older people who are homeless, former prisoners, living with drug or alcohol addiction, or living in severe poverty. So I'm going to talk a little bit briefly as well today about their specific experiences and the additional barriers they face in accessing healthcare. So I'll start off by just talking a little bit about older people's experiences of accessing healthcare, and it's reassuring, although obviously still concerning, to see that a lot of the findings that Healthwatch have found are very similar to the findings that we found from older people as well. That challenge in accessing a GP during this time has come out really strongly from the older people that we've spoken to. So older people telling us that they face really long phone calls to try to get through to their surgery, that they're waking up at 8 o'clock in the morning to try to get through, spending up to an hour on the phone and then hearing actually that there isn't any appointments available for them. There's also additional challenges for those older people that actually the cost of that is an additional barrier, and they can't afford to stay on the phone for that length of time. They're very concerned about that as a result. And we're definitely hearing from older people who have said, actually, it's just too hard at the moment to get an appointment. They feel like there's a lot of barriers standing in their way, which makes them think maybe they shouldn't be bothering the NHS at this time. And many people have told us that they've put off accessing the healthcare that they need as a result because it's too difficult currently. We obviously know that a lot of the appointments that older people have had during this time have moved to remote appointments. I think it's really important to say from the start, and this is again really very similar to what Healthwatch have been saying, that remote appointments do work well for some people, and I think there can be a tendency to presume that older people won't want to do something online or they won't want to have a telephone appointment. And I'll go on to talk about some of the challenges, but there are certainly some older people who have expressed that actually it's worked really well for them during this time. Particularly those older people who frequently have to attend appointments. They've said it's quite convenient. Usually they're travelling constantly during the week to go to hospital appointments and GP appointments, and having that option to do some of those check-ins over the phone at home has been really handy. We also know that a lot of older people during this time really are lacking confidence in accessing health services, in going into GPs or hospitals. So having that option to have the appointment remotely has been really reassuring for them. And there has certainly been some older people who have been really impressed that actually their surgery's done it really well. They can ring up in the morning, they've got an appointment a couple of hours later with their GP, their medication that they need, if they need a prescription, is in the chemist by the afternoon, and they've reflected on the fact that if they'd had to book a face-to-face appointment, then that kind of speed and efficiency would just wouldn't have happened pre-COVID. However, at the same time, we're certainly hearing about challenges that older people, I've gone too far. Yeah, so we're certainly hearing some challenges from older people who just really don't like remote appointments for a variety of reasons. We've heard from some older people that they actually feel quite uncomfortable talking over the phone. They feel like they're not as upfront and honest about their health conditions as they would be if they were face to face. We also know that some older people, there's a tendency for them to go along to speak to their GP, and there might be something that they feel very apprehensive about saying, for example, around their mental health, and they might casually drop it into conversation just before they leave the room. That isn't quite the same when you're doing it over the phone. There's a lot of concern as well from older people that they don't feel like they can describe their symptoms properly, and they're very concerned as a result of that about being misdiagnosed. We've also definitely heard from older people that have just told us that it isn't working well the way that their surgery is doing it. They are given a time when they can expect to hear from a GP or nurse. They don't get the phone call at that time, or they don't receive a phone call at all, and they're left going back and forth between the surgery and just feeling very frustrated and in limbo. And also, very concerningly, we're hearing from older people with hearing difficulties or cognitive impairment who these kind of remote appointments just don't work for them at all. They're feeling very disadvantaged and excluded as a result of that. They feel like their services just aren't there. And sometimes they've been calling for face-to-face appointments, and those wishes have just been disregarded. So they feel like there's no one for them to turn to at the moment. Building on that, we've certainly heard from some older people who have specifically asked for face-to-face appointments and had that request refused, even though the care that they need is something that needs to be delivered face-to-face. So, for example, hearing people who have been told by a hospital consultant that they need to have a face-to-face checkup with their GP, their GP hasn't offered them that, even when they've asked to, or things like needing their dressings changed, which obviously you need to do that face-to-face, or having tests, and that just not being given to them at a time when they need it. And we certainly heard as well older people telling us that they believe that remote appointments have led to worse care for them, and in some cases quite dangerous care as well. Older people telling us that they feel that if they'd been able to see someone face to face, symptoms would have been picked up much sooner, and they would have been prescribed the correct medication, and there's been quite serious implications as a result of that. So people telling us that they feel cancer diagnosis was missed, for example. I don't think it's something that we have the evidence to quantify the scale of that currently, but it's still very concerning to hear that older people feel like they have received worse care as a result of remote appointments in some cases. So building as well on the conversations we've already had from the other speakers today about digital exclusion, we've certainly heard from older people who don't have the technology or equipment to be able to do remote appointments over video consultation, who are unable to fill in e-consultations and as a result feel like they don't have a way to access their surgery. I think it's also really important to recognise that some older people do have digital skills and confidence, but their ability to do certain things really varies. So some older people might feel really comfortable, for example, sending an email. They wouldn't feel comfortable doing a video consultation, and actually the digital confidence between different older people really is very variable. Another thing which I think is really important to raise as well is older people being asked to take photos of their symptoms, sometimes in quite distressing circumstances. So, for example, we've recently heard from an older person who was asked to take a picture of their cancer to send to their GP, and they got in contact with a local aged care in floods of tears as a result of that, because they just felt it was very undignified and inappropriate. Or even just the difficulty of taking a photo of something on their leg, for example, if they find it quite difficult to bend, or just not having the confidence or the skills to take photos, and often sending photos to their GP, being told that the quality of the photo isn't good enough, and just feeling very frustrated that they've tried so hard to do something and it hasn't worked out. And again, this has resulted in some older people just not contacting their GP, having spent the last year maybe concerned about some symptoms or their health, but deciding that it's just not available for them at the moment, and they'll put it on hold until face-to-face appointments are back again. So as I mentioned at the start, I just wanted to briefly touch upon the experiences that we've also been collecting of older people who are socially excluded. So I briefly explained a little bit about this work. It's something that we've done with the Salvation Army. I think a lot of people don't necessarily, when you think of older people, you're not necessarily thinking of people who are homeless or people living with drug or alcohol addiction or former prisoners, but we know that this is certainly a growing proportion of the older population and is only likely to increase over the next however many years. So it is an issue that we're exploring increasingly at Age UK and the Salvation Army to try and understand these older people's experiences. This piece of research was really broad. It didn't just focus on older people's access to healthcare, but we did speak to older people pre-pandemic and then post-pandemic to hear a little bit about what their experiences have been in terms of accessing healthcare. And I think it's probably fair to say that many of the experiences that the general population of older people have, older people who are socially excluded are experiencing as well, but often in an exacerbated way. So we know that digital exclusion amongst these groups of older people tends to be higher for often just reasons that we might not even consider. So we've certainly been hearing from former prisoners who've been released from prison later in life that they're just not aware of technology that is now available. They find it very difficult to learn how to use this technology. They may have been in prison for a long time and aged during that period. They've come out, the internet's there, chip and pins there, just various things that we all take for granted that these older people just are unable to use. And there's also the additional challenges of older prisoners sometimes having restrictions on their internet use, which need to be factored in as well. We also know, and this has come up obviously a couple of times throughout the session today, but the cost of mobile internet or devices for many older people who are living in poverty, that's just not an option for them, and also not something they would necessarily prioritise if they've got limited funds and resources. And also just the homeless population who might struggle to, for one, have the devices, or also even to find somewhere to charge those devices to be able to access healthcare. This obviously has knock-on effects in terms of accessing healthcare, particularly as more and more of it moves to digital healthcare. So there's the fact that a lot of these older people, they've come out, they're living in these circumstances and might already struggle to know what services are available to them. They might not have the social networks in place who would be able to provide that information to them. And then the digital exclusion on top of that is a further factor. So they might not be aware of what support GPs could offer, for example. And that's certainly something that's been an issue during the pandemic as well, where many of these older people have struggled to access health advice or know what they should be doing to keep themselves safe during this time, because they haven't had that same access to the internet and resources that many of us have relied on to get our information. There's also the fact that many of these older people might already have difficulty engaging with services. These are
Charlotte,
Yeah.
sorry, I'm really sorry to interrupt you. Actually, we are running slightly behind time. So is it okay for you to wrap up and we can just go on to the questions?
Of course. Yeah.
Thank you.
I've only got one slide left anyway, so I'll leave it there and happy to take any questions.
Thank you.
I need to stop sharing now, don't I? Great, thank you.
Thank you very much. And I've seen in the chat there are many of you asking for the slides. We'll make sure you have access to all our slides and we'll email them. And I think we are going to publish the video as well, the recording on our website, so you can access it from there as well. Urta, do you want to join in here and sort of maybe start with your what you found, and maybe we can have a few questions from the public here?
Yeah. So yeah, we've got some time for questions or just reactions, responses, local experiences, if people want to put up their hands, and I'll also keep an eye on the chat. to kick off, Steve has already asked in the chat, how much research has investigated the differences between different tools for remote online access to GPs? Because they work very differently, and how much digital exclusion is driven by how GPs choose to implement the tools. So from our perspective, we didn't look at the different online tools, but we definitely found that there was a lot of variation, and certainly the implementation point, particularly on Ask My GP and e-consult systems, makes a big difference, particularly in the way that GP practices support people who may not be able to access those apps. As I said, you know, in some cases, if you don't want to use the app, you'll get talked through it, or a staff member will help you do it over the phone. And in some cases, they just say, well, you have to use the app. And yeah, so I don't know if any of the other speakers have any thoughts on the different tools point, or the point about how you can standardize the implementation of total triage systems, because at the moment that is more or less left up to practice discretion. Mike?
Yeah, just to say that it is left up to practice discretion. The CCG in North Central London are trying to get some standardisation for recorded messages. We did a mystery shopping exercise as well a few months ago to see what it was like trying to get through, and the recorded messages went on for ages. Some gave the impression that it was never going to be answered. Some started off with a statement about what happens if you attack their staff. It was very varied and totally inappropriate. So they are making some efforts on the other system. The systems, they're private systems. The GPs seem to make their own mind up, what they want to invest in, which makes it tricky.
Thanks, Mike. Anyone else want to come in with questions or thoughts?
I've just seen a comment from Alex, and they say that in the Southeast London borough of Lewisham, they have a very diverse community, and language issue is one of the problems they come across. So I wonder if either Alice or Charlotte, if you have something to add to that. Alice, do you want to go? You're on mute, Alice.
Yeah, sorry, I'm just trying to find my, I can't unmute.
We can hear you now. We can hear you.
Okay, great. Yeah, I mean, it's been one of those ongoing things that we've also found. Much of the information isn't designed in multiple language formats. It's also the level of literacy that people have. So you have the barrier of it's written in a language that isn't your first language. Also, just technical language is really difficult. And again, I think it's this idea of focusing on ESOL support and accessibility is really, really critical to make sure that services are inclusive for everyone, because we're finding that literacy and numeracy levels, as increasingly the service just becomes something that's digital by default, come into play as a big barrier as well. So integrating, making sure that you're thinking about that kind of ESOL support and accessibility from the start, and both in the digital design, but also in the digital inclusion support and wider support is really, really critical. So I would just completely echo that is a very big issue for a lot of people.
I see David's got a hand up. Oh, sorry.
Yes, sorry. Could I just, I was very struck by Alice's very well thought out presentation, and she raises the issue of the overlap between digital inclusion or exclusion and health inequality, which I don't think is in the public domain very much at the moment, because basically we're introducing a new technology which is adding to health inequalities. It's not subtracting, it's adding to health inequalities. So I work for Healthwatch in Reading, and I'm closely involved in the development of strategies for reducing health equality. And there is very little reference to the kind of developments that Alice has been talking about, which ought to be part of any health inequality reduction strategy in the new ICSs. There's very little reference to that. So I thank Alice for those comments, because I think we all need to take that forward into our own ICS and local neighbourhood and locality strategies as part of the general development of this new way of working, because it's going to be critical to getting rid of reducing health inequalities.
Thanks, David.
Thank you.
We're advocating for it, and I'm sure Charlotte is as well, because it just, I think that acceleration and just the assumption that has been made that this is going to be something that is able to make health something that more people can interact with and engage with has actually created a lot of barriers. If you just can't afford the access, the devices, the support, understanding, and that big thing around confidence and motivation, because it's not something, I think Charlotte gave some really good examples, it doesn't necessarily build trust for people having to do it digitally when you had a relationship before that you could actually draw on and give you that comfort.
Yes, thank you.
Yeah. I can see a few points in the chat drawing attention to the issues that GPs also face. Jill saying GPs are also having to adapt to remote working at pace, and Tom, who is a GP, saying I'd love to try and improve access, but we're overwhelmed and need to continue digital phone triage to the pandemic. We have little choice with platforms we use, funding to change our telephone solutions. Feel it needs action at a national or a CCG level, but also research into the platforms that work best for patients and clinicians. So yeah, really important points, and certainly the purpose of our work is not to point the finger at GPs. We're recognizing the exceptional circumstances everyone's been in during the pandemic. And I think definitely one thing we can take away from this, all of our organizations, is maybe looking at future research about the types of online platforms and how they change people's experiences. I'm just looking at the chat again. Claire, did you want to come in?
Hi, I would just like to say we at Redmoor Health have been currently supporting some of the regions in South East London and North Central London, giving support with the online consultation providers so that they give more information on how to use the products. I noticed that was some things that the GPs were saying about the ability to use the full functionality of the products. So we do that at the moment, and be happy to take any questions about them.
Great. Sorry, I'm struggling to keep up with the chat here, but it's great that people are having a good discussion. Hannah says, I work in reception, all very interesting, keen to make improvements to how the admin team support digitally excluded patients to access care. Do you have any tips, resources, or tools that we can use? For example, help for training admin to support patients. I don't know if anybody wants to come back on that.
I would just say that this is something that I know National Voices have been doing a lot of work around in terms of that admin element, and I think that there hasn't been enough thought actually in the past about the experience of that and how integral it is to people's experiences of healthcare in general, and actually having a really helpful person who works in reception can make the world of difference. So I'll find it now and share it in the chat, but they've done some work with people around that and their experiences and what makes a difference. So I will share that.
Okay, a lot of people also saying about the importance of social prescribing here in helping individuals to access support and digital tools. Is anyone, can't see, does anyone else have hands up in the?
I can't see any hands up, Uta, but there's a comment from Louise who says that NHSE are running several evaluations. One in particular is to look at the patient journey through several of the online consultation solutions to understand where the challenges are, with the aim to continue to improve the journey for the majority, but also for those in harder to reach groups and also for administrative and practice staff. So it seems like NHS England are kind of making some initiatives, so that really helps with our recommendations as well, and what Alison, Charlotte, and Mike have shared. So yeah, I guess we are just going to be bang on time at 11. So please feel free to keep your comments coming in, and we will share the slides unless someone else has anything to add. David, you still have your hand up. Is that a legacy hand, or do you still have something to add? You're on mute.
We still can't hear you, David. Okay.
Never mind.
He says, don't worry. Okay. Yeah, lots of fantastic comments in the chat as well. And thank you to those GPs and NHS staff who took time out of their very busy schedules to join us today, especially. Yeah, Amrita, I'll leave it to you to wrap up.
Yeah, thanks to everyone for joining us. As Arta said, yeah, we know that you all are really busy doing the frontline work. So thank you so much for taking time out and joining us. And it's been a pleasure to have Alice, Mike, and Charlotte, sharing your findings. And yeah, like I said, we will be sharing the recording of this session as well as the slides. So yeah, thank you very much once again, and have a good rest of the day.
Thank you.
Thank you.
Everyone.
Bye.
Thank you.
Bye.
Thank you.
Thank you.
Bye.
Thank you.
Thank you. Bye.
Bye.